afternoon, everyone. I'm Kristen Cocoman, President and CEO of the ALS Association Greater New York Chapter. Thank you so much for joining us for our Education and Resource Summit, Navigating the ALS Journey. In previous years, we've been able to hold events such as this in person, and we were determined not to let the pandemic prevent us from continuing to share valuable information and resources with our community. It is our hope that this week's virtual summit will benefit everyone, pals, caregivers, loved ones, friends, and more. Before we begin our first session of the week, we have a special welcome message from chapter board member, Dr. Kevin Glassman, followed by remarks from our Chief Care Services Officer, Tracy Sandy Ali. On behalf of all of us at the Greater New York Chapter, thank you again for joining us.
Good morning. On behalf of the ALS Association Greater New York Chapter's Board, and as a member of the Chapter's Care Services Committee, it's my pleasure to welcome you to the first annual Education and Resource Summit, Navigating the ALS Journey. Over the past 13 months, life has changed dramatically for all of us, but for families and patients having to manage with the struggles of ALS, the current circumstances of the COVID pandemic have complicated your lives even more, and we understand how these difficulties have been magnified. We put together a virtual program to keep you informed and engaged despite these impediments, and we hope that you find the next few days informative and helpful. The Greater New York Chapter's president and staff have assembled a talented and resourceful group of speakers for this summit, including physicians, researchers, nurses, social workers, and many others that bring years of experience and talent to this program. Over the next 3 days, you'll have the opportunity to take part in numerous sessions and conversations that span a wide variety of topics related to ALS. Everything from research and clinical trials to navigating the Medicaid system and so much more. No matter what's happening in the world, our mission to do whatever it takes to support the ALS community remains constant and steadfast. We at the Greater New York Chapter staff are here for you to support you as we navigate this journey together. Thank you again for being here, and I hope you find this program to be a valuable resource.
Everyone, and welcome to our first all-virtual ALS Education and Resource Summit. My name is Tracy Sandy Ali. I'm the Chief Care Service Officer for the ALS Association Greater New York Chapter. For the next several days, our chapter will present segments and breakout sessions intended to educate, support, and navigate our ALS community to helpful resources, expert insights, and new developments in ALS research. Along the way, it is our hope that you will get to know those of us who work at the chapter a little bit better, and you will enable us to become a part of your extended support network. So thank you again for being with us as we kick off this opening segment of the special 3-day event. It is my pleasure to introduce Dr. Gehrig Belsh. Dr. Belsh is a board-certified neurologist with 46 years of medical experience. He received his medical degree from Sidney Kimmel Medical College at Thomas Jefferson University in Pennsylvania. He has been seeing ALS patients since 1980. The Rutgers Robert Wood Johnson and ALS Greater New York Chapter relationship started about 26 years ago. It was formalized in 1995, and Dr. Belsh has been at the helm of New Jersey's first ALS Association Certified Treatment Center of Excellence ever since. I am honored to introduce Dr. Gehrig Belsh, who will be discussing ALS from the neurologist's perspective today. Please hold your questions until the end of the segment, or you can type them into the chat. Thank you. Gehrig, I'll turn the mic over to you.
Okay. Hello, everybody. I'm not as used to speaking in front of people I can't see, but I assume you're all out there, and certainly if you have questions, there'll be time for that. Now let's see, I have to do share screen. I almost forgot that. And share screen. share. All right, there we go. Okay, so you should all be seeing my first slide. And let's keep moving. What I'd like to do is start by just mentioning that when I started being involved with ALS, which I guess would have been when I was a fellow at Mount Sinai in 1979, more people call this disease Lou Gehrig's disease. So I thought we'd spend a little time talking about Lou Gehrig. Now, let's see, what do I have to do here to move on? Here we go. Okay. Lou Gehrig was, if some of you may not know, was a famous baseball player for the Yankees. He played his entire pro career, which was 17 seasons, with the Yankees, and he became famous as a great slugger, a great first baseman, and especially as a great human being. And this was even before he developed this disease. And just wanted you to see, those of you who know about baseball, the importance of his accomplishments. I'll let you just look at this slide, and I'll go. Of course, he was known as the Iron Horse because of his 2,130 consecutive games. These are some of his individual achievements. And that's supposed to be 545 in World Series play, 184 RBIs in 1 year. And during the time he played, Yankees won 7 pennants, 6 World Series. Lou Gehrig started declining in baseball during the 1938 season at age 34. He was at that time forced to end his famous consecutive game streak in 1939. They considered that streak to be unbreakable, and it stood for 56 years until surpassed by Cal Ripken Jr. of the Orioles in 1995. On July 4th, 1939, Gehrig was honored at Yankee Stadium. He gave a brief speech in words that have become famous. He said, "Fans, for the past 2 weeks, you've been reading about a bad break. Today, I consider myself the luckiest man on the face of the earth." Lou Gehrig became the first Major League Baseball player to have his uniform number 4, retired by any team. And I would advise you to try to get a hold of one of the books about his inspiring life, both before and after his diagnosis. Okay, let's start talking now about the disease eventually named after Lou Gehrig. ALS is the prototypical motor neuron disease. I hope you can see, if I point to something, will everybody be able to see it? I'm using my mouse here. The ALS involves motor neurons. That means the nerves that eventually go to help you move the muscles in your body. And we have involvement of motor neurons in the spinal cord, which are called anterior horn cells. And I'm pointing to where they would be because this is called the anterior horn of the spinal cord. And also the motor neurons that start in the lower part of the brain or brainstem, and these go to muscles in the throat and mouth and face. And then there are motor neurons that start up in the brain in the cerebral cortex. And of course, also damage in this disease then are all the connections to these motor neurons, which would be associated spinal cord, tracts, peripheral nerves, and voluntary muscles. And that would be this part here, let me just say, is the spinal cord sort of cut like a large cucumber. And that would be the same as the lower part of this diagram. So we see that the motor neuron has axons or long nerve segments that come down. Let's pretend this is the arm. They come out like a nerve in the neck, like when they talk about pinched nerves, that's where that would be. Come down through the shoulder and then down to the arm and eventually connect through the neuromuscular junctions to muscle fibers. The newer, let's say, a newer definition of ALS will include frontal and temporal areas of the brain that can result in mild to severe frontotemporal dementia. And I think you'll hear a little more about that in my talk later. Okay, now, diagnosis by the neurologist. I think neurologists are most known for using hammers and banging them on people's knees, but I think most of the patients know that we check a lot of reflexes, and it's extremely important. In any case, the neurologist must be totally familiar with the various presentations of various neurologic syndromes and diseases. So for example, he has to know a patient with tremor and rigidity may have a movement disorder like Parkinson's disease. A patient with confusion and memory problems may have dementia, which in turn might be Alzheimer's disease or some type of what we call metabolic brain disease or metabolic encephalopathy. And a patient with weakness involving, let's say, one side of the body. It may be a stroke if sudden, or a brain tumor if progressive. So now, understanding what neurologists have to know, let's get into the neuromuscular disease area. In this subspecialty, and I'm a subspecialist of neuromuscular diseases, we deal with all types of weakness and problems with sensation. Now, it happens that with ALS, the concentration is more on weakness, because the sensory nerves and systems are generally intact. Now, the neuromuscular doc must be able to elicit the various symptoms and signs of neurologic dysfunction. He or she does this by using a detailed and well-planned history. And the history part is when the doctor questions the patient and the family, and also reviews past medical records. Secondly, the doctor must perform a thorough and experienced neurologic exam to be able to collect all this information that we talked about and be able to put it in a category of neuromuscular disease versus movement disorder or stroke or epilepsy or things like that. For a diagnosis of ALS, we look for evidence from the history and the exam of some combination of what we call lower and upper motor neuron dysfunction. Now, I think most people who have have or have a loved one with ALS have heard those terms, but I'll briefly review them. Lower motor neuron dysfunction involves finding of muscle weakness, muscle atrophy, which means muscle wasting, fasciculations, or what we call twitching, muscle cramps, and decreased muscle tone with reduced DTRs, which is deep tendon reflexes, which are the reflexes that we use our hammer to elicit. Upper motor neuron dysfunction also will show weakness, but some of these signs are different. There's what we call spasticity, that's a tightness in the muscles, a lack of coordination in the muscles, and a feeling of stiffness in the muscles. And hypertonia is that stiffness that the neurologist feels when he examines the patients. And the reflexes, as I've explained many times to patients, instead of being absent or decreased, and instead of being just normal, are a little too normal, which means they're abnormal, increased, or we call that hyperreflexia. The lower motor neuron part is damaged to this part, this little blue line here going to the muscles of the arms or legs or trunk. Lower motor neuron is also involvement of motor neurons in the brainstem going to things like the palate, the tongue, the swallowing muscles, the speech and articulation muscles. Then the upper motor neurons are the ones that start up here in the cortex and send long processes we call axons that combine together to form what we call tracts, TRACTS, and this then connects with the lower motor neuron. So these are the areas that are involved in ALS. Now, if we just have, I'm going to start here, if we just have involvement of the lower motor neurons, that disease, these are actually might be called subtypes of ALS. That's called progressive muscular atrophy, or PMA. If we just have upper motor neuron involvement of arms and legs, we call that PLS, primary lateral sclerosis. And if just the muscles of speech and swallowing are involved, and these muscles are known as bulbar muscles, we call that progressive bulbar palsy, or PBP. Now, these last three are much less common than the full ALS. They often have a better prognosis than ALS, meaning a longer lifespan, but also each of these entities may progress to become a more widespread picture typical of ALS. Now, the neurology neuromuscular doc also knows that there are certain abnormal neurologic findings that are quite rare in ALS. And when we see these kind of findings in a patient, we have to think of other neurologic disorders. Okay, now, a few issues to bring up that, again, neurologist has to know. There are many different disorders that can present with just lower motor neuron dysfunction, such as diabetic neuropathy, carpal tunnel syndrome, pinched nerve in the neck or back, and traumatic nerve injury. There are many different disorders that can present with upper motor neuron dysfunction. For instance, multiple sclerosis, stroke, spinal cord injury. And there are even some disorders that can present with a combination of upper and lower motor neuron dysfunction. So all of these are not ALS, and it becomes quite clear that you need an experienced neurologist, and usually confirmation by a neuromuscular doc in order to make a correct diagnosis. Now, it is only after a correct diagnosis that the neurologist can proceed with a complete plan of focused patient management or care for that patient. In the early 1990s, my pulmonary colleague, Philip Schiffman, and I took notice that many of our ALS patients had originally been given incorrect diagnoses. These are known as false negative diagnoses because the correct diagnosis of ALS was missed or not made. So we did a study at that time of 33 patients that I had diagnosed with ALS. The study and several subsequent ones indicated a relatively high rate of ALS misdiagnosis in the general medical population. I'll show you what we found. This slide shows the misdiagnoses that were that other doctors thought were other neurologic disorders. We've already talked a little about this. Pinched nerve, brachial plexus neuropathy, which is the nerves in the that pass from the neck into the arm through the shoulder. Other diagnoses were multiple sclerosis, myelopathy, which is spinal cord problem, polyneuropathy, which is also known as peripheral neuropathy, and stroke. So in other words, these patients all came to me with these diagnoses, and we ended up deciding that they had ALS. There are actually other diagnoses that we might call medical disorders. People, in other words, people who eventually were found to have ALS were initially told they had melancholia, which in today's parlance would be depression or dementia. And you see carcinoma, pulmonary emphysema, congestive heart failure. So I think you can see possibly how these mistakes were made. Now, there is another type of misdiagnosis, which we would call false positive. That would mean that patients are referred to me with a diagnosis of ALS. They're told, sir, you have ALS, or ma'am, you have ALS. And it turns out after detailed exam and investigations that they really don't have ALS, but some other disorder. And just to give you an idea, I have some slides. Forgot that. Let me see. I am not up there, by the way. It's not good for my stomach to do those kind of rides. I'm going to actually ask people who are contacting Tiffany or if they know where these slides are from, because I decided to put a few in between slides, all from one trip that my wife and I took. I'm not going to tell you where it is, but you may have gotten some hints. Okay, let's keep going now. Okay, so these are examples of false positive diagnosis. It happened that this person had muscle wasting in the thumb area, below the thumb, that's called the thenar area. The person had muscle wasting, I think you can see right here, which is called interosseous muscle area here. And they thought he had ALS. And it turns out that when the MRIs were reviewed, he had considerable damage up in the neck area caused by bony outgrowths of vertebrae and discs. And this is an oldish, but this is MRI of the neck. And I don't expect you to read this, but normally this area, see the white area is just surrounding the spinal cord. And as you go down, all of a sudden you see this area coming almost to a point here, and then very thin here, and then coming out again, and then very thin. And these are all areas of pressure, compression by bony outgrowths that we call spondylosis. And this is a cut where they took an MRI right through the cord and the vertebrae. And you see this is the spinal cord, which is darker here in gray, should look like this. And so it's basically squished down almost to a pancake by this disc material here. Now I'll do another patient. This patient, as you can see, had weakness of his arms. He had some weakness of his legs, and he was felt to have ALS. And indeed, his older brother, who lived in New York, this fellow lived in New Jersey, his older brother had already been diagnosed as having ALS. And it was suspected that they had one of the newly found familial ALS syndromes. In any case, certain of his features didn't quite seem to fit in my mind. And we actually sent out a genetic blood test for a disease known as Kennedy's disease, also known as spinal and bulbar muscular atrophy. And this fellow was positive for that X-linked mutation. In other words, it was only found in men, not females. And later on, his brother was also tested and had that gene. So that's another example of false positive. One last thing, I just have one slide. Again, you see muscle wasting in the hands. But what happened was this never really spread anywhere else. And this diagnosis was given the term adult onset distal spinal muscular atrophy. Okay, so I just want to point out that misdiagnoses like these could also affect results of clinical trials. If a patient with a misdiagnosis enters a drug trial, his or her results might contaminate the other data because he actually never had ALS. We will be hearing more about ALS trials later in the summit. Obviously, we want to be absolutely sure that the patient enrolling in the study has a correct diagnosis of the disease being studied. And certainly all the investigators of these trials have to make sure that their patients come into the trial with correct, what we call entry criteria. Some people have asked me if I see as many misdiagnoses today as I used to see some 30 to 40 years ago. The fact of the matter is, I would say there are less false negative diagnoses, such as the study we did, some 30 years ago. But I would say there are more false positives. I think because of the so to speak, publicity of ALS and the hard work of the ALS Association to familiarize not only the general public, but doctors with ALS. Some of them are tending to make the diagnosis a little too much. So that would be false positives. Okay. Now I'd like to mention or talk a little about management, which is caring for the ALS patient by the neurologist. When I was a neuromuscular fellow, starting my training at Mount Sinai Hospital in Manhattan in 1979, Mount Sinai was one of only 3 or 4 ALS centers in the country. When our Robert Wood Johnson ALS Center started in 1985, and then we became an official ALSA center in 1996, there only were 12 other ALSA centers in the United States. I would say in the last 25 years, there really has been an explosion of interest in ALS, both clinical and research. And these centers and clinics have appeared in all parts of the United States. I did my own tally yesterday from the ALSA website, and I counted about 75 certified ALS centers of excellence. ALSA also has recognized even more centers that have not yet met all requirements for official certification. And there are a large number of excellent MDA ALS centers in the country. And this is some of the information that I just told you. ALS and ALSA have made their marks in the general neurologic world. And I would say that presently state-of-the-art management of ALS includes early referral to a multidisciplinary ALS center or clinic. And this has greatly benefited the ALS patient in need of expert and compassionate care. And as you can see at the bottom, studies show that patients treated at these centers get better management, and I think that says survive longer. Okay. I'm getting, and you may be getting closed captions, and some of the closed captions cover what's on the slide. Okay. Now, what is a multidisciplinary team? And this is what I mean by that there are multiple disciplines or people with different backgrounds in various medical fields that all are able to deal with different issues and problems and symptoms related to ALS. And we will be speaking a little more about this as we go along to see what kind of things our teams do. One comment about patient management. I wish I could announce, after being in this field for 40 years, that we have a treatment, either a cure or treatment of ALS, or something that reverses its ongoing progression. Unfortunately, as we all know, that is not yet the reality that we are hoping for. But I do want to talk about what we can do for patients and their families. Principles of management of ALS have not changed much over the last 40 years. Our therapists are still recommending many of the tried and true medical equipment and assistive devices that have helped so many patients over the years. And I have a few slides on this. So these would include AFOs, ankle foot orthosis, seat assist devices, and both of these from our PT physical therapists. Then there are, we have AAC devices, augmentative alternative communication devices from our speech therapist, and also computer systems and eye gaze systems. How about our dietitian advice about maintaining optimum hydration, and supplements with nutritional supplements. And I almost forgot about canes. And we have all kinds of canes. I mean, what you see here are canes that you're familiar with, but you don't have to be so plain in obtaining your cane. We have canes with decorative handles. We have canes with animal heads. We have canes with full body, full size animals. And we even have a cane with Atlas holding up the earth with his shoulders. Okay, so I want to review some general principles of management that we try to follow in our Neuromuscular and ALS Center. First of all, we want to, and one of the main focuses is to maximize the patient's ability to function despite his or her disabilities. We stress energy conservation with periods of rest. We advise the patient and therapists that work with the patient at home to avoid fatiguing exercises. We refer all our patients to a pulmonologist, a breathing doctor, experienced with ALS patients. And we do have an excellent pulmonologist and team of pulmonologists that have been working closely with our team for many years. We discuss in advance issues of later management, such as advanced directives, which is living wills, hospice care, feeding tubes, non-invasive ventilation, such as BiPAP, and tracheostomy with total mechanical ventilation. In other words, we don't wait until something is absolutely needed the next day. We like to discuss these things in advance, educate patients, and give them adequate time to talk with their family caregivers to make decisions. As I always say to the patient, whatever happens here, you will be in the driver's seat. You will decide with our advice what happens, and you certainly can refuse any treatment you think is inappropriate or might not be beneficial to you. We counsel patients regarding, and this is a lot of this has to do with the social worker, regarding insurance, community support, and help from ALSA, muscular dystrophy, and other regional ALS agencies. We provide psychosocial support regarding patient relationships with a spouse, caregiver, family, children, jobs, boss. We encourage patient participation in reputable ALS research and trials when these are available and able to be accessed. See, I have a slide here. I'm not going to go through the whole slide, but as I mentioned, frontotemporal dementia is certainly an important thing that we want to discuss with patient and family, as many families see some of these symptoms and features, personality changes, poor insight, decreased speech output, and wonder, is this really related to their ALS? What can we do about it, etc. And one thing that we want to let people know is, unfortunately, that compliance with treatment recommendations is often less in patients that have the ALS with FTD. Finally, as far as the principles, we want to assure the patient and the family that the neurologist and the ALS team will stay with the patient and will always be available to manage issues and problems. So we will never be throwing in the towel. And we always encourage contact with us. Now, there are certain things I will not be speaking regarding management here. I'm not going to get into symptomatic agents, including marijuana, which I think will be covered other places. I'm not going to be speaking of riluzole, which was the first FDA-approved drug in 1995. I won't be speaking about edaravone or radicava, which was approved in 2017. That's the intravenous medication. And the thing that sticks out in my mind is the $1,000 a day injection if you don't have insurance. I'm not going to speak about the role of genetics, genetic testing, and the C9orf genetic mutation. And I'm not going to speak about stem cell therapy. I think many of these will be covered in future sessions. I would just like to make a point about how researchers come up with all these new drugs and compounds to treat and potentially cure ALS. A lot of times you'll be referred to websites like the NEALS, Northeast ALS Consortium website, to find out about what trials are going on. You'll be referred to clinicaltrials.gov, which is the government website for all clinical trials going on in the United States. And you might wonder, what are all these drugs? What are all these compounds? About a year ago, I'm sorry about, this is more than a year ago, more about 10 years ago, I wrote out some tables to try to illustrate how researchers prepare to develop a cure. And I call these tables the good, the bad, and the ugly. So I'm just going to be brief with this. I used to, I don't know how sound would work on this. So I used to actually play this song, but you can all hum along with me, you know, da 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 da. Okay, here we go. So the good, basically in the research world, you know, 8, 9, 10 years ago, and many of these still today, these were the things that you wanted. In other words, you wanted to have glutamate transporters in your metabolism. You wanted to have chaperones such as heat shock protein. You wanted to have, you probably heard of neurotrophic factors. You wanted to have good axonal transport. Okay, you wanted to have all these things. So these are the things that you would want to give medication to improve or to increase or enhance functioning of these things. So that was the good. The bad were things that you would not want to be in your body because they might eventually lead to nerve cell death. And these things, for instance, You don't want mutant SOD1 because then you would have familial ALS, and that the damage caused by that may be quite serious. So we would like to get rid of mutant SOD1. And these are other things that we generally don't want in abundance in the body. I'm not saying we don't have any of these with inclusions and things, but we don't want a lot of them. Neurofilament disorganization will essentially damage axonal transport, for instance. Neuronal inclusions might clog up the nucleus and cause dysfunction. So these are the bad, and we even get worse than the bad. We have the ugly. I don't know if they still sell bubble gum with ugly stickers. Personally, I still have my 1960 collection of baseball cards. In any case, again, you will hear about these frequently during lectures about causes of ALS and about potential treatments of ALS. These are all the worst of the worst. Free radicals, oxidative stress, glutamate, excitotoxicity, apoptosis, etc. Misfolded protein, cytoskeletal. So we don't want those things. So basically the summary for these last few slides would be if this new therapy promotes the good or gets rid of the bad or gets rid of the ugly, then this drug or therapy may be worthwhile testing in clinical trials. And very often those clinical trials begin with animals, with mice, with rats, monkeys, etc. But eventually, and often, if they get the fast track, will go to humans. Let me see what I have next. Okay, I'm just going to end my talk with a little more information about Lou Gehrig. I believe he was certainly the first baseball player. I don't know if he's the first sports person, but to be on a United States postage stamp. And interest in Lou Gehrig's life has recently been invigorated by several popular books about him, as I mentioned before. Well, in my research for a book chapter, I discovered a connection with New Brunswick, New Jersey, where we are located at Rutgers. We're actually part of the bigger town, which some people call J&J, Johnson & Johnson. So Lou was a slugging star for Columbia University in the early 20s. As it says, he was known as Columbia Lou. It happened that in 1923, the New York Yankees scout, Paul Critchell, was on the lookout for some new talent. It was Critchell's luck that he happened to be in New Brunswick in the spring of 1923, viewing a Rutgers-Columbia baseball game. And what I decided to do was look up in the old Rutgers newspaper called the Targum, and I looked up that game, and I actually found a headline. This is April 26, 1923, where Lou Gehrig hit 2 home runs in that game. And it mentions, if you go through this, something about grooving the ball for Gehrig's home run drive, massive cloud over the right field fence, all in one inning, the 6th inning. So Lou Gehrig won the game. Critchell called the Yankees general manager that night, and the rest is history. And it mentions that this game was played at Nielsen Field. And I said, well, that field must be around somewhere. And I did a little research into that and went walking up the historic College Avenue of Rutgers, and I found where that field was supposed to be, and here it was. And just like maybe many other ballparks that have done their time, it had been converted into a 5-story parking lot. And I thought, hey, maybe I'd find an old ball hit by Lou and cash in, but no chance. So that is pretty much, I think, my talk. Let me see what I have. This is what I wanted to do. I did want to thank all the people on our team. These are the active medical health professionals and our coordinator, Mary Ann Mertz, who's been with me for, I think close to 15 years. And she actually will chair one of the sessions later in the week. My fellow neurologists, Sarah Chen and Megan Leach, who also take time running the center on certain ALS days. Our physical therapist, Lynn, occupational therapist, Tejal, nutritionist, dietitian, Anna, speech pathologist, Dory, and our wonderful social worker, Debbie Schlossberg, who I believe you will also hear from. We've been working with this combination of pulmonary physicians, Phil Schiffman, who continues to be in an emeritus capacity as consultant, and Andrea Harangozo as a chief pulmonologist for our patients. We wouldn't be able to, at least I wouldn't be able to function caring for ALS patients without each and every one of these people. And I am confident that at least at our center, and I think at all the ALS centers, you will get the best care available today. Well, we've all been through many months of the COVID pandemic, hoping to get out, hoping to see our families, whether it's parents or children or grandchildren. And I think that improvement is just around the corner, I hope. We will, I guess we'll continue now if there are any comments or questions. And so I'll give this over to Tracy, I guess. Thank you.
This is Tiffany. Thank you, Dr. Belsh. Tracy, did you have any remarks, or would you like me to go ahead and continue with questions?
No, Tiffany, you can go ahead with questions. Thank you. Thank you, Dr. Belsh.
You're welcome.
Great. Thank you so much. We've had a few questions come in through the chat. So I'll start with one that you sort of ended here on, which is about the COVID pandemic. Can you talk a little bit about how the pandemic changed the care delivery in our multidisciplinary clinics, or specifically for and with ALS patients?
Okay. Well, when things started, basically the entire medical school functioning switched pretty quickly to the virtual platforms. In other words, being able to talk started out maybe with phone calls, and then with the type of video system that we have now. As far as the ALS patients, we generally have 3 sessions a month, 3 full-day sessions a month, sometimes 4. And we did not have patients here until, I don't know exactly, but roughly August or so. And we started having patients come back to the clinic on the appropriate days. Now, when we started, of course, some patients still wanted to be on the virtual, and the way we handled that was, there were various ways of doing it, and what we ended up doing was we have a feature called doxy.me, which is similar to Zoom, and Mary Ann had her sign-in password. I had mine, and then eventually each of the team members had their own, and the patient would have to go on to this system to see each of the team members. And then at the end of the day, when we had our team meeting, we would have this through either something like Zoom or WebEx, and so that all 6 or 7 or 8 of us could meet without having to be in the same room. And at this point, I would say we're seeing most of our patients in the clinic. We're having our group meetings. Of course, we're always wearing masks. And I'm happy to say that a large percentage, maybe most of our patients have now been vaccinated. I saw 3 patients already this morning, and all 3 have been vaccinated within, have gotten their second shot at least 2 weeks ago, and their spouses also have gotten shots. So that's very, I find that very rewarding.
Okay, great, thank you. A little bit more on multidisciplinary care. What do you think the future is for multidisciplinary care, and or what sort of changes, if there are any, would you like to see in that particular model?
Well, I think the most important thing is to have regular, dedicated team members. In other words, you want, when you go in to see the physical therapist and occupational therapist, you would like people that are not going to treat you as if, well, you're just like another sports injury that hurt your nerves, or you're a Parkinson patient, or you're a stroke patient. You want people experienced with ALS patients, experienced with the changes that occur. You want therapists to be flexible, so that they're always looking to see if there are any changes. They give you a chance, the patient a chance to speak, and they come up with creative solutions. So I don't think there'll be a lot of changes coming up. Some of the technology has improved, like communication technology has improved. The cell phone, the smartphone, we use that a lot. We provide or advise people about apps to help with speaking and communication, which has tremendously brought the price down. There have been other ways of other types of feeding tubes that sometimes we recommend put in rather than by GI specialists. They could be put in by radiologists. Also important, of course, is that the therapists care about the patients. And I've been very, very happy with our therapists over the years. And these therapists generally supplied, you might say, by the hospital. And our hospital, Robert Wood Johnson, has been very cooperative over the years to provide these people, because they're all very busy seeing patients, inpatients, outpatients throughout the week. And I could see their interest and concern for the patients at our team meetings.
Okay.
Yes.
I'll just throw this in there. We did have some guesses on where your trip was. It looks like either Denmark and or Copenhagen. Two different answers here.
Okay, so it happens that it's not too different. It's the same answer because Copenhagen is the capital of Denmark. And whoever both said that is correct. And it was a fabulous trip. And it was actually the beginning of a trip that became a cruise of the Baltic countries. So we spent several days in Copenhagen at the beginning and several days at the end. And in between, we went to Stockholm, Sweden, Tallinn, Estonia, St. Petersburg, Russia, and Helsinki, Finland. Unfortunately, you're left with basically sort of like a half a day in each place and just get a little flavor. The tip off here with Denmark was first those colored houses in an area off the canal called, well, it's spelled Nyhaven. I know it's not pronounced Nyhaven in Danish. And then, did anybody see the building that said Tivoli? And then there's those rides. That's the world famous Tivoli Gardens, which is the amusement park, probably the first amusement park in Europe. And then the lots of bicycles. If you don't watch where you're going, you get run over by a bicycle.
Well, thank you so much for sharing a little bit of a place far away from here for a little bit. I'm going to go on, continue with some other questions that we have coming in. What's your opinion regarding GABA, reduce glutamate, and do you also believe in reducing exotoxins from your diet is helpful?
Okay. One of the drugs that we use, riluzole, is supposed to, in some way, reduce the toxic glutamate. As far as taking, I'm not exactly sure of the question is, but there may be compounds out there that claim that they'll get rid of the toxins in your body. What kind of toxins did they mention, Tiffany?
Sorry, 1 second. Exotoxin,
exotoxins, I think.
yeah, sorry.
Which is excitatory toxins. So I'm unaware otherwise of any, medicines now other than, the approved medicines for use in the disease for those features. I think there are probably some that are being brought up, and you'll hear more about that in discussion on drug trials.
All right. Another question we have is, have you found that patients with a positive attitude or an approach of take one day at a time not only live better, but possibly longer?
Well, to say that they live longer, we'd really have to have and I haven't specifically studied that, so I can't say anything as far as, conclusions that this is true. I could say that patients with a positive attitude will be more active, tend to avoid a depressed mood, and decreased activity and depression can lead to physical dysfunction, such as increased, let's say, contractures in the limbs. Depression, often we get reduced desire to eat, and therefore can lead to malnutrition, dehydration, So a positive attitude is very important for the patient.
Okay. Next question. Has electrical stimulation been shown to have any positive effect on neuromuscular function?
We have generally have not found that to be helpful. Now, there's several different types, but what you have to understand, what happens here is not only the both the nerve and the muscles are damaged. The nerve by the disease, by the motor neuron disease, and then the muscle fibers that are innervated by the nerves are damaged. So if you're stimulating either one of those, you're working with damaged nerves or muscle fibers, and the stimulation is not, unfortunately, is not going to bring them back. I know there's also a voice stimulation technique that the speech therapists use. We have tried that in the past, and the therapist didn't notice any improvement in speech function using the what they call, I think they call it the speech stim or electrical stim. Okay.
All right. How often have you noticed weight gain in ALS patients, or is that not usually normal?
I would say that weight gain is not common because there are several reasons to lose weight. One is just loss of muscle mass from the disease will cause weight loss. It can become difficult to keep up with the metabolic needs of the body and the muscles. And so the decrease in your nutrition may result in weight loss. Then, of course, if somebody has some difficulty swallowing and find themselves coughing with each bite, or choking, or just not getting it down, these patients will tend not to want to eat, and that means less input of calories and protein. A person may have quite good swallowing, but if their arm is weak and they have trouble feeding themselves, we found that patients will tend to put off meals or cancel meals. So we don't see a lot of specific weight gain, and therefore our dietitian generally encourages people to eat and to avoid weight loss or calorie loss or protein loss diets.
Okay. And it looks like our final question, unless we do have about 6 minutes left. If you have any last questions, go ahead and type them in and I will get them to Dr. Belsh. But it looks like our final question at the moment is, what advice do you give to someone who's just been recently diagnosed with ALS?
I explain what the disease can affect in the body. In other words, this disease affects the motor nerves, which in turn affect the muscles, and it affects the voluntary muscles. That means the muscles that you can move. So any muscle in the arms or legs can be affected, and affected means muscles getting thinner, muscles getting atrophied, and muscles getting weak. And then I mentioned the muscles of speech and swallowing, and I mentioned the breathing muscles. I explain the purpose of our center and why it would be worthwhile for the patient to attend an ALS center with a multidisciplinary clinic. I explained that by coming to a clinic, and that does not have to mean mine, Robert Wood, the closest other places are usually New York or Philadelphia. Now there are a few other centers that are opening up in New Jersey that I know that ALS is connected with. Of course, we would tell them that you won't have to be coming every week, 3 times a week for physical therapy, but rather when you come every 3 months, we try to advise people on what therapy they need, what they should do at home. If they do need a home physical therapist or occupational therapist, we talk about the medications, Riluzole, Radicava. We talk about the importance of seeing a pulmonologist, a breathing doctor, and we talk about clinical trials, how they're done, where they're done, who's participating, and where to look for them. I mean, this gives you a little idea. We might not cover everything on the first visit or the second visit, but eventually things are discussed as needed.
Okay, we do have a few more questions here. I'm going to try to get to them all, but one I do want to highlight right now, considering we already kind of talked a little bit about vaccination. What would you tell an ALS patient who's concerned to get vaccinated due to their minimal research? Is their full question.
Definitely get the vaccination. I don't have any doubt at all. I don't have any question about that.
And would you say, I think Dr. Fauci has said something similar to whichever one is nearest you, all 3, at least the ones that are here approved in the United States, are equally good?
Yes.
Okay, just in the last couple of minutes, another question on weight gain, comment on weight gain from a tube feeding.
Do people get weight gain on tube feedings? We try our best for the patient to maintain weight and not to lose weight. Generally, gaining weight, as I said before, has not been a problem.
Okay, if a patient has FTD, would this be identified on an MRI or just by a clinical presentation?
Generally, a clinical presentation. Often it can be further, where it's a question, it could be further diagnosed with what's called psychological testing, a series of written testing sessions with a neuropsychologist. Yes, the MRI generally will not be helpful in diagnosis, at least presently.
All right, and just in the last minute we have left, I want to remind folks, We've tried to answer all your questions, and if we didn't get to your question, we will follow up with you. So please attend the wrap-up session if you are able with the chapter staff on Friday at 3:45 p.m. to answer any outstanding questions. The questions in the chat have been saved. We will be able to get answers to you all. And thank you for attending our first session today.